All right, now we're being recorded. And when this meeting is over, the recording will be posted on the commission's webpage shortly after the meeting. And I'll pause and go back and say, welcome everyone to the December meeting of the Universal Healthcare Commission. We're being recorded. It'll be posted on the webpage. It may also be streamed on TVW, archiving it for additional viewing opportunities. For everyone's reference, today's agenda is under the first tab in the materials. And now Vicki Lowe, who's chair of the Universal Healthcare Commission, will call our December meeting to order.
Welcome, commission members. It's now 2:02 and I call the December 5th meeting of the Universal Healthcare Commission to order. I'm going to start by doing a land acknowledgement. I'd like to begin by acknowledging that as we gather today, we are on the home and the ancestral homelands of Indigenous people. For me, that is my ancestors, the Jamestown S'Klallam or St'át'imc S'Klallam. We honor Indigenous people despite being removed from their lands where they lived, hunted, gathered, practiced ceremonies, and cared for their community members. And we honor Indigenous people and tribes, whether officially recognized by the United States government or not, as they continue to care for these lands and their community members. As health professionals, it is important that we also acknowledge the impacts of the removal from traditional lands, of children stolen to boarding schools, of the oppression of culture and traditional ways of life on the health of Indigenous people throughout the country and in Washington State. As we work to improve health in Washington State, it is imperative that we address these inequities of the past by understanding their impact in the present. I invite each of you to learn about and understand the true history of the Indigenous lands where you live. All right, so I want to give a warm welcome to everyone. Thank you for joining us today. If we open, we've got the agenda up right now, and we'll do a brief overview of the agenda. And then we're going to do roll call. And just a heads up, our question this month is, what is your favorite meal to cook and why? And then after roll call, we'll approve the October meeting summary. Then we will have our state agency report out. That will be followed by public comment. And then we will hear the updates from the FTAC committee. And then that will be followed by an update from Evan Klein from the Healthcare Authority, who's going to give a presentation on state approaches to access and affordability. And then Liz Arjun from HMA will lead us in a discussion on cost containment, building on the FTAC updates and the presentation that we just heard. And then following that discussion, we'll take a 10-minute break and come back and spend the last hour of the meeting on our 2025 work plan. So any questions, comments? All right, I'm going to turn it back over to Mary to go through a roll call.
Good afternoon, everybody. Hello again. When I call your name, please unmute your microphone and let us know you're here. And a reminder, the question of the day is, what is your favorite meal to cook and why? So we'll start with Chair Vic.
I'm here and I didn't take time to think about the question, but I think my favorite meal is I like to make homemade pizza dough and then cut up a bunch of stuff and put it on the counter so everybody can make their own little pizzas. And my kids even got me a little pizza oven outside so we can cook it with the big paddle and put it in there like they do at the restaurants.
Thank you. Senator Ann. Senator Ann. Adisha.
Hi, I'm here. I have to think about what's my favorite meal to cook. Perhaps noodles. I think it's easy to make. I can just throw in whatever in there, and yeah, I think maybe that's just because of the ease.
Charles.
Yeah, I'm here. I don't have a favorite meal to cook, but just generally like to use cooking as a relaxation. So just for me, cooking is like therapy, and I just like to take the time to detach from work and to do something else that is not work. So just enjoy cooking.
Dave?
Good morning, everyone. Anyone that knows me well knows that I am a horrible cook, so I can only do things that have like salt, pepper, and one or two other ingredients. So fried egg sandwich, that's me.
Thank you. Senator Emily? Senator Emily? Jane?
Good afternoon, everybody. My favorite is, here I am giving an endorsement to Instant Pot, but I'm sort of with Badisha. I can throw everything into a pot and come out with a really good soup or stew, or at least my husband says it's really good.
Thank you. Joan?
Hi, everyone. That's so funny, Dave. I totally second the fried egg sandwich. I would say I assemble much more than I cook. And one of my favorite things to assemble is nachos.
I think assemble and apply heat count as cooking. Representative Joe?
Takeout. And part of that is warming it up if it's cold.
Thank you. Representative Marcus? Representative Marcus here? Okay. Mohammed?
Oh, hi everyone. Yes, I've tried to cook a few times, but my older kids give me a lot of hard time. The one thing that I think they tolerate about my cooking is the pasta, so I try to make that as much as I can.
Thank you. Nicole?
Everybody loves pasta. Hi. Let's see. Mine is caldo de res. It's like a Mexican beef stew or soup, and it's like thick, hearty, warm. It reminds me of home.
Omar? Omar. We had heard he might be having some internet issues. And Stella? Hey, thank you, everyone. I'm going to turn this back to Chair Vicky, who will move to the meeting summary.
All right, if we can move to tab 2 in your book. The recording of the last meeting is on the Healthcare Authority web page for the Universal Healthcare Commission. Also, we'll vote on the approval of the October meeting summary. Is there any discussion on the summary or any proposed changes? I propose that the minutes are accepted without any change. Is there any discussion? Or a second?
I'll second.
Thank you, Nicole. I'm sorry, my phone is taking everything down that I'm saying. It's kind of freaking me out. All those in favor say aye.
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 I
Aye.
Any opposed? Say nay. Okay, motion carries. All right, and then if we move on to tab 3, we're gonna do our state agency report outs. I know this is a little earlier than usual, as this is our first meeting since the November elections, and there have been a lot of changes with elected officials at both the state and federal level. We really wanted to provide an opportunity to discuss what this means from our state agencies. So we understand it's still very early in transition process, although I see a lot of things happening. We are hoping to hear from our commission members about any updates from their agencies. So I'm thinking we sent this out, the order, I don't know, but I have Jane, then Charles, then Dave, Joan, and Omar. Does that sound okay?
Yep.
All right, go ahead, Jane.
So we have a commissioner-elect, Commissioner Patty Cooter, who will be sworn in on January 15th. And I think for any of you that heard her speak at all during the campaign season, you will note that she spoke very, very clearly about her support for universal health care, and is letting me know about all the concerns that she heard about healthcare when she was out on the campaign trail. So I know it is an issue of great importance to her, and that the work of the Universal Healthcare Commission also is of great importance. So we look forward to continuing to do good work.
Thank you, Jane. Charles, do you have an update?
Yes, just a few updates from the Department of Health. One, as you know, many of you may have heard or know already, our current secretary, Dr. Shah, will be stepping down January 15. So, we're preparing both for the governor transition as well as looking forward to the new secretary come next year. And, just looking forward to continue to build on Dr. Shah's legacy, including continue to focus on our agency priorities, and really just appreciate him as well for his, emphasis on the stronger connection between the public health and the healthcare system. So just one of his legacies that I'll be looking forward to carrying forward into the next administration. If lead session, we're preparing for lead session. In addition to work on our priorities for the session, we're also working to implement a few laws, including the certificate of need review that was mandated by the legislature. So initial draft has been put together with regards to the recommendations after the review of the certificate of need program. So for those who may not be familiar, this is the program that regulates the process for essentially giving approval for any hospital or healthcare system proposing to build new hospital beds. So there's a process they have to go to receive an approval to do so. And that program, so it's undergoing a review, and there is currently partner engagement on the recommendations to review the feedback before the final draft is made. Also, the other, I think, important update is on the state health assessment. So this is where we work with partners across the health ecosystem, in community-based organizations, and really essentially any major organization that has an interest in health in the state. So this is something that should be done more often, but the process has kind of been stalled by the pandemic, so we haven't had one in a few years. But that process has started. So there's a state health assessment that happens, and then it ends with a state health improvement plan. So right now we just convene the SHIP Alliance. So the SHIP is the state health improvement plan, and we try to build a cross-sector partnership across the health ecosystem to contribute different perspectives to that process. So the SHIP Alliance has been reconvened, and we're just looking forward to that partner engagement over the next year or so to finalize that SHIP development process. Those are a few updates that I have for today. Happy to answer any questions related to that.
Thank you, Dr. Shima. Dave, you're up next.
Hi, everyone. The Healthcare Authority. We have a new governor-elect for the executive branch, and that much we know. Most agencies, the Healthcare Authority is not excluded from this, are awaiting a variety of appointments, including the next director of the Healthcare Authority. And so Sue Birch will be stepping away come January as well. Many folks are aware that state agencies, again, Healthcare Authority is just one of many state agencies, but is working through recent gubernatorial executive order about freezing related to travel hiring and contracting. And so we are in the current process of reviewing not only all pending contracts, all pending hiring, all pending travel, all previously approved, but upcoming travel, upcoming hiring, all of that effective the last roughly 2-3 days. And so working through all of those pieces as we all prepare more for the challenging budget environment that is coming, that so many of us have heard many different descriptions of, but all of them challenging when it comes to the operating budget that the legislature will be working on and the governor's office will be working on for the next biennial budget. It's also no secret that state agencies worked in collaboration with OFM to produce information about potentially legally available but non-prioritized opportunities or instances of things that could be utilized to balance the state budget. So none of those things, there is a published page on OFM's website with various information from executive agencies about those potential legally available options for the state budget. I do want to emphasize that, especially at least for the Healthcare Authority, the only one I can speak for, they're not prioritized. There's no guarantee that any of those will or won't be used. We don't have any specific insights about how likely or unlikely any of the things that were described. But for our agency and our part, we did create a robust list of things that were at least potentially on the table or possibilities from a legally available kind of standpoint. So we've been fielding a lot of questions about that, but again, we don't know where any of those conversations will lead at this point, but the information is available. We do have a variety of pieces of agency request legislation that we're working through. I think there's really only one that is of primary relation to this commission's work, and Evan Klein is here this afternoon to talk about that piece, so I'm not going to steal his thunder. This is legislative report season. We have several dozen legislative reports in the month of November and December that get produced. I wanted to call attention that the Health Cost Transparency Board annual report was recently released. Many people are interested in the PEB/CEB consolidation report that has. We are anticipating that will be released sometime towards the end of next week or the beginning of the following week. We do have a page on the Healthcare Authority's website. If you just Google HCA legislative reports, we put hyperlinks to not every report that we produce, but ones that are of particular interest. And so that will be one along with the Health Cost Transparency Board report that's already up. So that's a centralized page that we produce. We are preparing for Assembly Days next week. There are 9 presentations just from the Healthcare Authority for various committees next week. So, tune into TVW for an opportunity to watch us as well as other agencies presenting to both sides of the legislature. And then when it comes to federal things, we all know that change is coming in about a month and a half. And so the agency is working with CMS on some of the final touches on various components of our Medicaid waiver to finalize things with the current administration before changes happen at the federal level. And so there's a lot of activity in that range as well. And that's what I have for today.
Thank you, Dave. That was great. Oh, yeah. Yesterday was kind of a nerve-wracking day. Joan, I just came from an exchange meeting. So.
I was there with you. I saw you leave and I thought I should leave if the chair's leaving. Quick updates from the exchange. I think my public service announcement to everyone who is working with customers and clients who are client facing. We are currently in open enrollment for the individual market and for the exchange. So anyone who is still needing insurance, wanting insurance in the individual market, wanting to take advantage of federal subsidies at the level they are while we still have them, wanting to take advantage of Cascade Care savings, highly encouraged to do so. I think the new kind of coverage pathway or subsidized coverage pathway that's available that we're doing a lot of outreach and engagement on is related to DACA recipients. If you're a DACA recipient or you have another qualifying status, starting November 1st, you could newly access federal subsidies. So that's messaging that you'll see coming from us and on our social media accounts and through our navigators and otherwise, really encouraging people of any immigration status to continue to come in and get covered. I think messaging at the federal level around DACA has been get it while you can. So I think there was a woman from Washington who participated in a recent national webinar who spoke about getting health coverage and sort of encouraging others to do the same. So lots of, in the wake of sort of federal election and federal election rhetoric, lots of fear and concern kind of bubbling up around continued privacy protection and continued access to some of these programs. So you'll see some joint messaging come out from the exchange and healthcare authorities soon, speaking about the continued program availability and continued privacy protections for communities that may be feeling impacted or targeted of late. I would say with regard to the federal transition, there's sort of two main areas that we're watching. One is affordability and one is access. So on the affordability front, Congress can take no action and the federal subsidies will expire, enhanced federal subsidies will expire at the end of the 2025 plan year. That's something that is now largely being anticipated. So I think that's one thing where there's a legislative ask this session from the exchange to think about maintaining or possible increasing the state subsidies to help mitigate some of the affordability impacts that we are expecting from the loss of the enhanced federal subsidies. On the access side of the House, in addition to closely watching what's going to happen with the DACA recipients and the new access they have to federal subsidies and the DACA program in general, we have our state waiver, our 1332 waiver that is approved through 2028, but can be sort of rescinded as desired based on Health and Human Services Secretary, is what's allowing people who are undocumented to purchase qualified health plans on the exchange. We're the only state in the country with a waiver that is allowing that to happen. So in contact with our federal partners and our community-based partners to do some contingency planning there in the event that it becomes of interest at the federal level. And that, again, we'll be working with OIC, HCA, others on ways to sort of maintain a continuous coverage pathway for the about 2,000 people who are covered today. To the legislative report season, we have our report on auto enrollment that is coming later this month. It'll be available on our website in early January. We were asked to kind of look and see what other state-based marketplaces were doing to help enroll people who are turning off of Medicaid. We have a large population of people who turn off Medicaid and who are eligible for health plans in the exchange, but don't end up signing up for one. And working with our partners at DSHS to look at the demographics of who we're losing, and as a result, who auto enrollment might help sort of provide continuous coverage for. So that'll be coming soon, and I know that's an interim solution that has been of interest to this group, so we'll make sure to report back and make sure that report's available to everybody. That's it for me.
Thank you, Joan. And Omar, did Omar get into the meeting? I
don't think Omar's here.
Did you say he was having trouble? Okay.
Yeah.
All right. Is there anybody else that has an update they want to share related to just the change in administrations? All right. Well, thank you all for all that information, and I look forward to reading those reports. I'm one of the nerds that reads those.
Vicki, the only thing I was remiss in adding that I think we are all actively monitoring at the agency level is, we're obviously watching to see what the continued trajectory is around the Affordable Care Act in general. Yeah. And I think Jane's probably well positioned to speak to the protections we put in place in Washington and the codification of the key parts of the Affordable Care Act that exist. As a broader state, we also have a lot of waivers that we rely on, to Dave's point about finalizing the waiver. So I think we'll all continue to work together to be monitoring what, if any, proposed changes there are to the Affordable Care Act. And I will say this, as a group, we're very familiar with the potential repeal of the ACA. So it's not new, but did want to mention it for completeness.
Yes, thank you. Yeah.
Hopefully it's gone out of fashion, repealing the ACA.
Right. Although I will say to Joan's point, Joan is right. During the 2018 and 2019 legislative sessions, and then when we initially implemented the Affordable Care Act, many of the provisions of the ACA are in state law. Guaranteed issue, preventive services, coverage of dependents. I mean, there's a whole long list. But the one that we worry about or think about the most that could be done through the federal budget reconciliation process would be changes in the federal subsidies that are provided to individuals who are enrolling in coverage through the health benefit exchange. So that's the big one.
Mix well with the budget forecasts for
With the state budget forecast. Yeah, I don't want to call it a perfect storm, but I think we are all having those thoughts about affordability.
Thank you. Last time offer, Nicole, did you have something to add? I saw you came up for a second. I don't know if that was just.
No, not at the
Okay.
moment.
All right, thank you. Thanks, everybody. Okay, next up, we have public comment, and we're actually 3 minutes early. But I think we're okay to move forward with that, Mary. Does that sound okay?
Sounds good.
We're usually behind, so I don't even know what to do. Public comments received since our last meeting can be found under tab 4 in your book. We also allow individuals to sign up to provide public comments before the meeting, and we will start with those who have signed up. If you've not signed up and would like to provide public comment, please raise your hand on the raise your hand icon on the bottom of the screen. Mary will call on you after we hear from those who had signed up. When you are called upon, please state your name and any affiliation you may have before speaking. Please do not raise your hand more than once. That helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in written via email at any time. To ensure that everyone has a chance to speak, there's a limit of 90 seconds per person, which may need to be reduced if we get closer to the time limit for public comment, and we're giving 15 minutes for that today. We will be displaying a timer as a reminder of the limit. When the timer stops, please stop your public comment. We encourage public comments to be focused on the materials and topics being discussed today. We may run out of time for public comments. If we do, you are welcome to submit your comments in writing. So, Mary, will you please start with the names of the individuals who've signed up for public comment?
Todd will get our timer started. 2 people signed up ahead of time for public comment, and the first person who signed up was Catherine Lewandowski.
Hi, can you hear me?
Yes. Hi.
Okay, sorry. Yeah, hello, members of the Universal Healthcare Commission. My name is Catherine Lewandowski, and I'm a retired registered nurse and vice chair of Whole Washington. Wow, it's been an interesting roller coaster of events over the last month or so. I think that it can be fair to say that economic relief was a main concern amongst the electorate at the ballot box across the country. It sort of feels good, though, to see how here in Washington, we are very well positioned to actually provide the type of relief that our citizens and residents truly need from our elected representatives. At Whole Washington, we are excited that we have a governor-elect who is in support of a state-based universal health care plan. We have elected a head of the Office of Insurance Commissioner who is also very supportive of a universal state-based system and in favor of true healthcare reform. In light of the expected projected budget deficit, we feel that it is even more important that we focus on looking at how we can best provide the economic relief to residents and also help to stimulate our state's economy. At Whole Washington, we feel that the Washington Health Trust is the best mechanism for providing that relief efficiently and comprehensively. We've recently finished our recommended changes to Senate Bill 5335 and are very excited about how these recommendations from our small business communities look on paper. We'd like to ask the Commission to please request a dynamic fiscal note on our new Washington Health Trust language as soon as possible. Although I had provided a snapshot of our proposed changes to the FTAC last month, a lot of discussion amongst our organization and other communities led to some changes, and I would like to send you our final proposed funding changes in writing and also the FTAC that is currently being sent in for pre-filing. And thank you for your time and all your work serving on the Commission, and I hope you have a great holiday season.
Thank you, Kathy. The next person who had signed up ahead of time is David Loud.
Hello, thank you, commissioners. The commission's, I don't know why I don't appear there, but anyway, the commission's milestone tracker shows just one area of completion, eligibility in the universal system design. But even this topic is really far from completed. I'm sending in a written comment, so please look at the latest iteration of the Healthcare for All Washington's Health Security Trust proposal, which lists eligibility issues that, to my knowledge, the Commission has not yet discussed, such as voluntary enrollment, automatic enrollment at birth, definition of all residents, residents temporarily out of state, who work in another state, or who live in another state but work in Washington, those who need specialized care in another state or country. At the October meeting, I want to add, I heard it said that veterans would not be eligible because they have the VA system, but only a minority of veterans use the VA. Even for those who do use it, some are not eligible for all VA services and must also rely on other sources of care. I believe the universal system should welcome any veteran who elects to use it. Final comment, the milestone tracker is a great idea. Please make sure that it's accurate, that it is date stamped for every update. The Commission needs to pick up the pace of work. Thank you. Please go at it.
Thank you for your comments. I think, and now with those are the folks who signed up ahead of time, and I see Ronnie Shore's hand is up. I think that's the first hand that came up.
My name is Ronnie Shore. I'm a retired pharmacist and volunteer as the president of Healthcare for All Washington. And I really love cooking chicken with this fennel to add a fragrance of licorice, and then add a tarragon and fennel, tarragon and mustard pan sauce. But what I wanted to do today was to urge the commissioners to support Healthcare for All's legislation about reference-based pricing for public employees and school employees. Oregon has used that successfully. Our Cascade Care program here in Washington State has used it successfully. I think it's important for this commission to support what the Healthcare Authority is suggesting later in today's meeting so that similar results, similar savings can occur with our state. Thank you for this opportunity and for the work that you all are doing.
Thank you. I don't see any other hands up. Give that a few seconds, or maybe someone else sees one that I'm missing.
Don't see anything.
I think that's it for public comment today. Thank you, everyone.
All right, thank you, Mary. Thank you, everyone, for your comments. Hearing from our community members is very important. We really appreciate those who take time to make comments or to send us comments. There's the written comments that we received since the last meeting. And next we'll move to the update from FTech from our Financial Technical Advisory Committee liaison, Pam McEwen. Pam?
Hi, Vicki. Thank you. And good afternoon, everyone. I'm going to report on our most recent meeting and happy to entertain questions or comments as we go along. Can we go to the first slide, please? So the November meeting covered prior authorization, which was at request of your committee. And then we continued to work on cost modeling and cost containment, updating on the Milliman work, and an introduction to reference-based pricing as a possible cost containment mechanism that could be viable both for transition solutions and long-term solutions. Next slide, please. So prior auth. Prior auth is like everything else in healthcare. The longer you look at it, the more complicated it gets. And you had asked us to work on this with you. So initially we looked at it as an interim solution, sort of thinking that similar to your conversations, that gold carding and standardized forms seemed like the most promising to make changes. But we also noted that prior auth changes should be part of kind of an overall cost containment model and part of long-term reform as well. We were cut short. We ran out of time. We have a similar problem to Vicki, which is our meetings don't always run on time. So the conversation was cut short. You were kind of asking your indulgent bear with us, and we will be discussing this again at our next meeting. Next slide, please. And then the major chunk of the meeting was spent on cost modeling and cost containment. FTech liaisons, we have 3 of our most experienced folks on our group are meeting, I think every other week, roughly, with the Milliman team to kind of go through questions and comments to guide the work of Milliman. There's been a slight delay in scheduling due to data sharing requirements. We expect final results in March next year. Next slide, please. So what we are, working both on cost modeling and cost containment. The initial topic, as has come up a few times in this meeting already, is reference-based pricing. So following the direction of the October Commission meeting, FTAC began its examination of reference-based pricing. And we are really fortunate of having Robert Murray on our team, who's an expert on these topics. He presented on cost containment models, particularly taking a deeper dive on the focus on reference-based pricing. It's a result of that discussion and presentation, FTAC agreed with the following by consensus, and I will read these. Recommend that UHCC consider supporting transitional efforts which utilize reference-based pricing. Recommend that the Commission consider including reference-based pricing and other cost containment strategies for universal design. And FTAC will continue exploring cost containment strategies as directed by the Commission, assuming that we will go kind of deeper into longer term solutions. Next slide, please. Bob Murray went through kind of a public utility model, which is structuring healthcare costs similar to how we think about public utilities. And then looking at, potential for standardized pricing. In addition, we began discussion and listened to him discussing some things that have some real potential, which is price caps, particularly looking at state and public employee health benefit programs where the state has latitude, and looking at out-of-network care. That's an area where other states have made headway into look at a cost containment strategy of limiting costs for out-of-network care and hospital global budgeting. Next slide, please. Looking ahead at our January meeting, we are going to continue the prioritization of included benefits and services and looking at Universal Healthcare Work Group final report. These are the models that we are looking at. And it's the essential health benefits that are defined by the Affordable Care Act, which are the underpinning of Cascade Care. Dental for Medicaid eligible only, and then vision, and then long-term care for Medicaid eligible only. Are there any questions or comments or good advice for FTAC? Representative Schmick.
Could you give just a brief clarification on the global hospital budgeting to what exactly that means, please?
Yeah, I will, I know that the slides from our presentation were sent out to the committee. So if you have a chance to look at those, I'd encourage that. Bob Murray is really the expert, but global budgeting is just like what we do with the rest of the world, which is we know how much money we have to spend, and then we spend within the limits of that. So hospitals in a lot of other systems have a budget, or there's an overall, depending on the entity you're thinking of, but a hospital global budget would be, we have this X many millions of dollars, and then you live within that budget. Does that answer your question?
I get it. I guess the question would be about the details about that, how those details then are determined. I will
Yeah.
look for that, what was sent out, and,
Yeah.
and take a look at that presentation.
Yeah, I would note that what I found really interesting when he presented to us is exactly what you said, the details. It's not a simple thing to do, and you need the kind of the surrounding infrastructure to determine what would be the right number, how you would come up with that, and how you would really essentially have the oversight of the health systems that were under global budgets. Jane.
Can you go back a slide, Pam? So price caps versus reference pricing.
Mm-hmm.
What's the thinking on the distinction between those two?
So reference pricing, I think, well, which is so, and price caps, I think that my favorite example is out of network care, which is you determine that, that at some, you can't go above this number, which provides a really strong incentive for providers and carriers to come to agreement, because there's not an incentive to keep bargaining.
To stay on the network.
To a certain point, you're not going to go above this. Then that's the way that works. Does that help?
Yeah. Yeah. I mean, capping out of network rates, I know Bob's spoken about that a lot, and some would say that the failure to cap out of network rates in the Federal No Surprises Act has yielded an independent dispute resolution system that is not what Congress anticipated.
Correct.
In terms of how frequently it's being used and what the results are.
Right. I heartily agree. And I felt like when we had the presentation, the out of network care showed a lot of possibilities. I think I don't know, I'm not saying this was underlying Representative Smith's questions, but it certainly made me think of, it's just, what's the feasibility of some of these things, given the infrastructure that needs to be developed? And I think what was appealing about reference-based pricing and out-of-network care, particularly when we're looking at transitional solutions, is they just seem much more feasible within the state structure that we have today.
Right. The other thing I would note, and I am happy to share it with the commission when it comes out, is January 1, the Office of the Insurance Commissioner is going to be releasing our second Balanced Billing Protection Act cost impact analysis. So we'll have 4 years worth of data about what trends are we seeing in terms of shifting from out of network to in network care, and what kind of trends we're seeing in the rates that are being paid. So that might be helpful to folks.
Yeah, I know FTAC would definitely be interested in that.
Yep, I will, as soon as it comes out. We're finishing it up.
Oh, good. And I was just going to say, Bob Murray's actually on the call, and I was going to ask if he wanted to add anything. So go
here's
right
our expert.
Yes. Yeah. Well, thanks, Pam, and Vicky and Jane. I was just going to mention, I think, when we talk about reference-based pricing, really the mechanism is referencing to Medicare to set a price cap in the context of either state and public health benefit program, where you would say, okay, here's the limit. It's going to be 200% of Medicare, just as Oregon had done for their state and public employee program. And then you set that cap, and that's the maximum that would be paid. But then if prices previously were negotiated that were lower than that cap, those would be the prices in effect as well. So you have to avoid having prices gravitate up to the price cap itself. That was an issue that Oregon encountered when they first did their state and public employee price cap program. But then for out of network, it's the same thing. It's setting a price cap reference to Medicare, but applicable to commercial prices for out of network services. And what that does is two things. One, it truncates the high out of network prices that might otherwise be negotiated between an insurer and a provider. But it also, based on evidence that I've experienced myself and also evidence from the Medicare Advantage program, setting a price cap on out-of-network prices, as Jane indicated, referred to earlier, has the effect of giving insurers additional leverage, negotiating leverage, to negotiate lower in-network rates. That's at least the theory and the experience that the Medicare Advantage program has witnessed. So it's a little bit of an indirect approach, but it has the benefit of capping high out-of-network prices, but also conferring additional negotiating leverage to insurers to negotiate lower in-network prices. And then the third program, which I'm most familiar with because we implemented this in Maryland, are hospital global budgets, which are a broader mechanism that would control both prices and volume growth over time. And you know, in future sessions, I'm happy to elaborate on any of those, but I just wanted to provide those clarifying comments.
That was great. Thank you.
And I guess one thing I'll just pop in with one thing is in the affordability report that OIC released in August, we actually have an analysis of reference-based pricing that repriced commercial health plan rates to Medicare and showed where prices currently are for about 15 categories of services. And we'll be presenting that report to the House Healthcare and Wellness Committee on Monday.
Great. Representative Schmick, did you have a question? I thought I saw your hand.
I did. It was for Robert when you were saying about the global budgets and the cap of growth. Is that when you're talking about caps of growth, is that number of procedures that you alluded to, or a rate of increase being capped?
Well, really, it's both. The global budgets that we implemented in Maryland for hospitals, first, it took their historical revenues from a previous year and just used that as the baseline amount of revenue that they were approved to earn in a future year. But the rate setting authority in Maryland also had the ability to control the rate of growth of those budgets. So it sets a firm or a flexible cap on the amount of revenue the hospital can earn during the year. And then it also controls the rate at which that budget would increase over time. So it really does both. And it has basically incentives for hospitals to try to improve their cost efficiency, as well as not do unnecessary services, unnecessary care over time. I mean, there are two different models. One is more of a kind of a fixed cap, where it limits the hospitals to a set amount of revenue no matter what, or an alternative approach that I've recommended, which is more of a flexible approach, which pays the hospital, it gets a little technical, but pays them their variable costs for growth in their revenues to cover their variable costs. But also when volumes decrease, it provides hospitals a sufficient revenue to cover their fixed costs. So it's beneficial to smaller hospitals that are losing volumes, while at the same time capping or providing an incentive for hospitals not to increase volumes unnecessarily. I mean, I'm happy to go into, in a future meeting, do a presentation or go into more detail about it, because this does get a little bit technical, but it's just generally an aggregate cap on the amount of revenue the hospital can earn, as well as controlling the rate of growth year to year of that hospital budget.
Thank you. Are there other questions?
I just want to note that Mary put the report that Jane was referring to in the chat box if people want to click on it and read it later after dinner.
Okay, Bob, thank you for being on this call. It was really helpful. And I think that wraps it up, Vicki.
Hey, thank you. I'm not going to jinx anything by noting the time, but and Evan is here, right? I thought I saw him. Okay. All right. So thank you, Pam and Bob. We really appreciate you guys and the work you're doing and all the details that you take care of and bring information back to us. So thank you for being here. So continuing with more information on reference-based pricing, we have Evan Klein from the Healthcare Authority. He will present about the PEBSEB access and affordability, and then we'll have a discussion with Liz from HMA and a possible potential vote after that. So Evan, go ahead.
Thanks, Vicki, and I'll just check. Can everybody hear me okay?
Yeah. Nice and clear.
Perfect. All right. Well, thank you for having me here today. Here to talk about a proposed agency request bill from the agency for this upcoming legislative session around reference pricing. I think the conversation that preceded this presentation really set the stage well. So I will probably skirt through some of the background around this bill and focus a little bit on what it does and be available for questions. But Audrey, if you want to advance to the next slide. Did want to give you a bit of background about what led the agency to the decision to propose legislation for this upcoming legislative session. A little bit of background on reference pricing, but I'll be brief given Pam's presentation and some of the conversation. Summary of the bill, and then some goals and expected outcomes associated with it. I'll also note as I get into the materials here, one, we have a suite of other materials available for those who might be interested. The bill is published online. As well as a short fact sheet. We have some additional materials that we're also in the process of finalizing, including an FAQ document around this legislation that we can certainly get through staff to the committee, or to the commission, I should say, if there is interest. And those should be available here within the next couple of weeks. So some more to come. Next slide. And actually, you can go ahead to the background slide. Thanks. So a couple things led us to deciding to propose legislation this upcoming session. One of the biggest factors, aside from rates and price increases, is actually recent contract termination notices by large health systems. I imagine many of you have felt this within your health coverage. There's been a lot in the news recently, but health systems in contract disputes with health plans, we believe mainly related to rates, but very public disputes that have trickled out into the press. It's created a lot of concern for the clients that we serve, issues related to potential network access for enrollees, and concerns about plan selection and how they should choose their health coverage, as some of these termination notices have ticked up right around open enrollment periods over the past couple of years. So part of this legislation's intent is to be sensitive to the fact that contract terminations are really disruptive for health plan enrollees. They create access issues, and taking on issues related to affordability becomes difficult if you don't do something about access at the same time, because if you just were to depress costs in the system, we know that there's some optionality for large health systems and hospitals to participate in networks. So contract termination notice is definitely something that was top of mind leading into our decisions. And then cost growth, right? You've heard a lot about it here. And for those who participate or listen to conversations by the Healthcare Cost Transparency Board, there's been a lot of dialogue over the past 2-3+ years about cost growth in our system and hospital services and their cost growth, particularly. Outpatient services have been the largest kind of single bucket of cost growth over the past several years. And that largely kind of holds true across markets. In PEB and SEB particularly, our rates, those are kind of the bid rates, so premiums in many respects, have grown by 20% from 2021 to 2024. And this is at the same time that Washington has been investing in other publicly funded healthcare, right? So you have probably heard about the need for cost shifting across markets. And something we've been sensitive to is one, what does research say around cost shifting? And we can get into that more in a second. But two, if it's true that hospitals, health systems, providers are seeking higher rates in commercial insurance because of lower rates from Medicaid or Medicare, then when we're investing as a state in some of those public sector coverage or public coverage, we should hopefully see commensurate reductions in price elsewhere, right, if that is true. We're also proposing this legislation on the heels of legislation that was enacted in Oregon. They have a very similar reference price cap at 200% of Medicare that was instituted in 2019 in the state. And there's been some recent analysis of that showing some significant benefits to the state that I'll get into in a second. As well as some experience here in Washington. And many of you are probably privy to our Cascade Care program here through the individual market. We have Cascade Select plans that are offered on the individual market that also utilize a reference-based price structure that I'll get into in a second as well. So those are the main components. The other piece that I don't want to miss is kind of chronic underinvestment in primary care and behavioral health. Another kind of issue that we've been very sensitive to here at the Healthcare Authority, particularly as it relates to Medicaid, but also in the commercial insurance space. We know that access still remains a challenge across sectors or across healthcare markets, and primary care and behavioral health access is, are two areas where we're seeing some of the biggest challenges in accessing providers, recruiting providers into the workforce, retaining providers in the workforce. And we, in this proposed legislation, are thinking about ensuring there are payment floors for these critical services so that we're redistributing dollars towards, high value preventative care as opposed to paying, more and more for specialty services and in hospital services. Next slide. I won't spend too much time here because I think Pam did a great job of outlining kind of what reference pricing is. Generally speaking, it's looking at another market that has established payment rates and referencing prices to that. In many cases, Medicare is the payer that's referenced to because it's a transparent payment methodology. It's established at the federal level. It's known and commonly understood by providers. So there's a lot of consistency created by referencing to Medicare. And we've seen both in Washington and in other states, this is commonly utilized as kind of the benchmark when establishing any reference pricing policies. Just as a bit of background, sharing kind of where some of our payment rates are in UMP, which is the self-insured portion of our PEB and SEB portfolio. As of 2023, we were paying facility inpatient outpatient services. So those are hospital services at around 210% of Medicare, behavioral health services at around 109% of Medicare, and primary care services at around 150% of Medicare, just to give you some sense of where we are today. Next slide. So I mentioned both of these already, but a little bit more detail here. Two kind of reference price programs that we were looking to with a critical lens as we were contemplating proposed legislation for our PEB and SEB program here in Washington. I'll make clear these aren't the only two reference price programs that have been implemented nationwide. There are a number of others. There are also some other approaches, again, that Pam went into and Jane went into to controlling costs. So reference pricing certainly isn't the only way to target affordability. But these were two programs that were very familiar to us and that have shown success, right? So where can we take lessons learned from successful initiatives that are already in place and build on those for our public and school employees. So Cascade Select, as you're familiar with, right, it's the individual market public option program. It's been in place now for, I believe, 3 or 4 years. It caps payment for all services, so it's not focused on hospital services, but in the aggregate at 160% of Medicare. It also sets some payment floors, so primary care services must be at 135% of Medicare or higher, and critical access hospitals and sole community hospitals must be reimbursed at 101% of allowable costs. And that's a reflection of the need to ensure that our rural providers are continually paid at least their costs so that they're not losing money on individual market coverage. And I think the benefits of this have been pretty apparent. There's statewide access effective in 2025, and it's been the lowest cost silver plan in 31 counties. And there may be some changes that I would defer to Joan on current figures, but I believe that was as of 2024. So it's showing to have lower rate increases relative to other plan offerings by the same carrier year over year. And it's proving to be an affordable option on the individual market relative to alternative offerings. The other proposal that we were looking to when contemplating legislation was Oregon's reference price law. So they actually have a statute that's in place, took effect in October of 2019. It was passed in 2017, specific to their public and school employee benefits programs there. It caps hospitals at 200% of Medicare. It exempts certain small and rural hospitals, so it takes a slightly different tact for those facilities. But their program was found through a third-party audit to have projected savings of over $112 million in 2021. So that's over the first 27 months, I believe, or so of the program. So significant savings to the state. I'll note it's not captured here, but there was a subsequent analysis of out-of-pocket spending impacts of the legislation in Oregon, and that found a roughly 9% decrease in out-of-pocket spending by consumers who were utilizing services at hospitals that were impacted by the legislation. So it's not just a premium impact, it's not just an impact to the state's budget, it's also an impact to consumers and what they're paying when they receive services as well. But again, some fruits of the labor in Oregon. There's been a lot of literature on Oregon's reference price law that has recently been published, given some of the studies that were just completed from those first couple of years. So happy to pass that through staff if there's interest. I think even as recently as this Monday, there was a new study out of Brown University on the legislation and some of the impacts there. Next slide. So not going to spend much detail on it here, but just sharing, again, there are some other reference price laws that we did look to. Oregon and Cascade Select were the two that are most prominent for us here in Washington, but did just want to provide you a couple of additional references of where other states have explored utilization of reference pricing to control costs. Next slide. So to our proposed legislation, the summary of the bill, it applies to all fully insured and self-funded medical plans within our PEB and SEB portfolio. For those who aren't as aware, today that includes our Uniform Medical Plan, which is administered through Regence, as well as Premera and Kaiser Permanente. Those are the three kind of carrier offerings within our PEB and SEB market. It requires hospitals to participate in network upon a good faith offer to contract from the carrier TPA. So as I referenced at the beginning, contract terminations and termination notices were something we've been very sensitive to. And we know that state employees and school employees have been very sensitive to over the past couple of years as those termination notices have ticked up. We also recognize that, as I noted, it's difficult to do anything on affordability or to drive down costs without also working to ensure that networks remain robust and that access isn't challenged as a result of providers fleeing a network because they don't want to see their rates reduced. And so we recognize that some sort of either incentive requirement or incentive or requirement for participation is really necessary to be paired with affordability policy to ensure that you're not narrowing networks at the same time as you're trying to reduce costs for enrollees. So in this case, we took the same approach that our Cascade Select legislation took to requiring hospital participation in those networks. The bill also caps carrier reimbursement for inpatient, outpatient hospital services at 200% of Medicare. This begins in plan year 2027, begins in calendar year 2027. It would require critical access and sole community hospitals be reimbursed at no less than 101% of allowable costs. So again, picking up some provisions from the Cascade Select legislation here, recognizing there's a need to ensure, a payment floor for critical access and sole community hospitals, given there's such a cornerstone of rural access in the state. And it does set a separate payment cap for children's hospitals. We recognize there's uniqueness to the services provided at children's hospitals. And there's a justification for higher reimbursement rates in those settings. So in lieu of carving them out, recognizing they do still drive costs for consumers, they have significant impacts on premiums, we are setting a separate cap that is higher at 350% of Medicare. In 2029, both of those caps are slightly reduced. The inpatient outpatient hospital cap reduced to 190% of Medicare, and the children's hospital cap reduced to 300% of Medicare. I think as we were envisioning where to go with this legislation, we felt that there were some long-term goals for kind of sustainable reimbursement levels that we were hoping to achieve, but felt a phased-in approach would prevent certain shocks to the system and allow for an incremental reduction in cost without starting that all at once. So you see this kind of phased in over a 4-year time frame, really. Next slide. And then again, as I mentioned, this also includes payment floors for certain critical preventative services. So the focus is on primary care and non-facility behavioral health services, particularly those services where reimbursement is low today, kind of below 150% of Medicare. As I referenced, this is very acute for behavioral health services where reimbursement today in our Uniform Medical Plan averages around 109% of Medicare. We know there's a need to invest more in these kind of preventive services to incentivize providers into the workforce, retain them, increase access. And we felt that this kind of redistribution of reimbursement, this redistribution of cost made a lot of sense. Again, building on some of the provisions that exist in the Cascade Select legislation around a primary care floor and thinking about behavioral health as another kind of critical service category that made sense for a payment floor. Beyond that, the bill requires carriers to take into account these changes in reimbursement from the legislation in future rate development cycles. It's hard to say that reductions in spending on services, the allowed amounts paid by the plan, translate one-to-one to premium reductions because there's a lot of other factors that impact premiums and our carriers' bid rates year over year. But we are requiring that the carriers and our TPA for UMP would take this into account in the rate development cycles with the goal of driving any cost containment that's achieved by the legislation directly to consumers, directly to the state budget. And it requires some reporting requirements as well. We recognize kind of one piece of this is we need to monitor the impacts, not just on our PEB and SEB coverage, certainly understanding, any changes to premiums, any changes to out-of-pocket costs for our consumers or our enrollees, but also what are the impacts to the rest of the state, impacts to other markets, what's happening with this as kind of a, cornerstone for affordability for our public employee coverage, and how does that impact reimbursement and cost containment throughout the state. So, reflecting on that in a report back to the legislature by 2030. Next slide. So what are the goals of the legislation and expected outcomes? Certainly we want to maintain access to critical hospital services. We, are proud of the coverage that we're able to offer to state and school employees. We are proud that, we have both a generous benefit package and robust health plan networks that are available to people who want to commit to public service, and we want to maintain that. We want to ensure that individuals who are enrolled in our state purchase coverage can get access to hospital services when they need it around the state. We want to increase access to behavioral health and primary care services. We think there's still a need to increase access in these spaces. And we hope that increases in floors around reimbursement can achieve that. And then inevitably, we want to contain costs. We recognize that the current costs for consumers and their kind of continual growth over time are unsustainable long term. And the goal of this legislation is to ensure that we can contain costs. So part of it is, can we achieve some greater affordability today, but long term, how can we contain some of the cost growth that we've seen in the market? And we recognize the legislation is focused on hospital services, but again, that's a reflection on where we've seen the most growth and the highest costs to date. And particularly where the state has any semblance of kind of regulatory control. Initial modeling on this it's actually public. It's included in our decision package that was provided to the Governor's Office and Office of Financial Management back in September. We anticipate some of this cost modeling will get updated over time, but our modeling around our uniform medical plan data alone suggests some cost avoidance in the realm of $56 million beginning in 2017, increasing to over $150 million by 2030. When you look across all of our plans, those figures look closer to around $75 million of cost avoidance in 2027, increasing to over $240 million in 2023. So across kind of the fiscal year 2025 to fiscal year 2029 landscape that the legislature might be budgeting against, that's cost avoidance of over $400 million potentially if this legislation were to pass. And that's inclusive of the increased investments particularly in behavioral health services, where we would see, just for uniform medical plan coverage, potential increases of over $23 million each year. Obviously, these numbers come with a lot of caveats. They're based on existing utilization and data from plan year 2023. So we expect some changes to them. And I wouldn't suggest that they would translate, again, kind of one-to-one to savings assumptions, but trying to give some sense of scale. And again, Oregon, for reflection, passed their legislation, had to see it mature over a couple of plan years, and then was able to audit the impacts to determine what savings were realized by the state there. But again, kind of saw savings in the realm of $112 million over the first 2-ish years of that program. So with that, that was a lot of material, but I'm happy to take questions or otherwise turn it over to Liz, who I think was going to facilitate a discussion.
I don't know if you could see Representative Schmick has his hand up. Sometimes when you're presenting, it doesn't show up.
I didn't know if I should. I don't know if I should.
Oh, wait,
call
where'd he
him.
go? Now Dave has his hand up too. Representative Schmick, did you have a question, comment? 3 questions.
Okay. With the projections for increased for the behavioral health, will this $23 million more, will this get to your goal? You had said earlier in your presentation you were 109% of Medicare.
Mm-hmm.
Will this achieve that goal? And I guess the next question would be, what is the goal?
Yeah, so we have essentially set a target in the legislation of ensuring our plans are paying at least 150% of Medicare rates for behavioral health services. So the modeling, that $23 million is a reflection of the amount of increased cost it would take, again, using like 2023 utilization to increase reimbursement rates to 150% of Medicare. So the goal is increase rates to at least 150% of Medicare, with the hopes of achieving increased access, and the belief that it would achieve increased access as a result. But hopefully that's helpful.
No, it answers the question.
Great.
I am a bit concerned, even though the goal is paying appropriate 101% of allowable costs to critical access hospitals. I've got 8 critical access hospitals in my district, and the margins that I'm watching that they currently have, they're thin. And so I'm just wondering, has there been some analysis done? Because I guess I am concerned about the overall financial health of these hospital systems, throughout the district. And it's not just my district, but across the state, with these price controls that are put in place for reimbursement. And so I guess it's a comment and a question. I have concerns about their critical access hospitals. Has there been thought given to that? Thank you.
Yeah, it's a great point, Representative Schmick, and absolutely something that we have taken under consideration here at the Healthcare Authority in contemplating the legislation. We recognize that the goal here is to contain costs for consumers, and particularly those costs can be really acute for individuals in rural communities. And we also recognize that the cost centers and the large cost drivers tend not to be the facilities and the providers in those rural communities. And so it's something that we're hypersensitive to. We do have some additional data that we could probably work with you offline to just kind of share kind of where we are today with payment rates for certain hospitals, and talk a little bit more about what the impacts of this legislation might be at a kind of, more individualized level. But it's, certainly something that's top of mind. We imagine will be a topic of conversation if this bill, if we're able to advance this during legislative session. So don't want to lose sight of that at all. And I think your points are really well taken, Representative.
Okay.
I think Dave, I don't know, Vicky,
Dave, and then Dr. Chima, yeah.
Yeah, my pieces aren't questions. They're just context reminders for everyone who doesn't live and breathe Peb and Seb every day. Just a reminder, it's about 775,000 covered lives between the over 700 public employers that participate. Some required participation, some voluntary participation, and about 690,000 of those lives are in a medical plan right now. That other roughly 85,000 difference are people who either waive coverage and or are only enrolled in dental or vision care, but they are all lives within the portfolio. A little over half of all of those lives, about 54% are in the uniform medical plan. So about 410 to 415,000 lives. And the one question that I get many times throughout the year, and I just think it's a good reminder, is that the rates that are set, or the premiums that are set for the uniform medical plan, and the modeling around that self-insured plan is run by the Healthcare Authority. We consult with actuaries and actuarial analysis for it. But a question that we always get is, why did Regents raise the rates? And we always have to explain, Regents didn't raise the rates. Regents isn't even in the room when the rates on the plan are set. They do contract and provide they do the provider contracting, and we have, under our contractual TPA arrangement with Regents, performance guarantees and accountability and contractual requirements around cost containment in those provider contracts. But when we talk about like the claims experience that is realized and the liability that is with the state, so if there is this downward pressure and cost avoidance, there is a much closer relationship to the state budget and being able to scoop that up more immediately or more purposefully when it comes to the uniform medical plan. So that's why I described the big numbers about the 54%, and how there is a closer relationship. So when Evan highlighted a slide or two ago that there's this requirement that carriers take into account all of this when producing bid rates, that's absolutely the requirement when it comes to fully insured. HCA is closer to the numbers and closer to the management of the cost from the claim standpoint when it comes to UMP. And that's the point I just wanted to drive down a little bit more in my insights. So I'm going to hand it back over.
Thanks, Dave. Anything to add to that, Evan? Nope.
Oh no, Dave always says
I
it
know.
more articulately than I.
Thank you. Dr. Chima.
Yeah, thank you, Dave, for that additional background. So just a few, I guess, follow-up questions. The first, thank you for the presentation. This was really helpful. And so first I wanted to, in addition to the additional context provided by Dave on the numbers in terms of a number of enrolled lives, can someone provide a sense of PEB as a player, in the healthcare system, in the state, like what, how big a player are we talking about relative to, to Medicare, Medicaid, and other players in the system? So I'm just trying to figure out to what extent these changes impact, potentially could have an impact on decision making, right, of the players looking at these signals and kind of where you want them to know to pay attention to. And then related to that, so one is kind of PEB as a player and how big a player it is in the system relative to others, and how this could have downward effect. The other is, so the primary focus is on cost containment, but obviously this would have implications for access. So could you talk a little bit on the evaluation side in terms of what kind of metrics and in what ways are you going to be able to monitor and be able to see whether it's intended or unintended consequences on access, right? And so if I look at the summary of what you presented, you're essentially incentivizing more primary care and behavioral health, hopefully, and trying to cap inpatient costs. So can you speak a little bit for how you can actually measure the impact of this on the system, and in what ways do we expect the players in the system to be able to read this signal and be able to really kind of follow along the queue to say we need to start, building more capacity in primary care and behavioral health, for example?
Those are great questions. Thank you, Dr. Chima. So the first, I think, Dave, please feel free to supplement me here, but whenever I talk about PEB and SEB as kind of a portion of state coverage, I usually suggest kind of roughly 10% of the state's population. It tends to be a little bit less when you carve out some of the retiree groups that wouldn't necessarily get captured directly by this legislation. But, thinking about the state as roughly 7 million covered lives, the PEB and SEB program covers roughly 700,000. Dave, is that a correct reflection or how you would frame it?
That's one way that I frame it. The other way to frame it is when you talk about commercial lives in the state, the estimate that is PEB and SEB are around 18, 19 on a rosier day, 20% of the commercial market.
Yeah, because roughly 2 million are Medicaid covered lives, and I think it's somewhere in the range of 1 million around Medicare. So,
yep.
So that's to your first question. The second question on evaluation of access is great. And so certainly the reporting requirement that we're kind of directing of ourselves includes a evaluation of impacts on network access. And I think, we have a couple of tools where we would be able to monitor that over time, right? We recognize it's sometimes hard to isolate for specific impacts of legislation. And in this case, with so much else that's happening, like with primary care investments that may concurrently be taking place or not within Medicare and Medicaid, as well as, investments in medicine, family medicine residency network and other GME programs in the state, right? Like there are some difficulties in isolating for reimbursement rate specific impacts on incentivizing providers into the workforce, especially in a short time frame. But I think there are kind of a couple of acute data points that we would look to. The first certainly is with hospital providers. We'd want to look and ensure that we're not losing major hospitals or health systems from our health plan networks. And again, reflecting on Oregon, to date, they haven't seen hospitals that had been in network prior to their legislation being enacted, moving out of network. And then beyond that, right, looking at, are our health plans meeting network access standards? Are they meeting their network adequacy standards? I think, Dave, and you can correct me if I'm wrong here, but we get some information reported from our plans on access, enrollee access to different provider types. What is your wait time to going and seeing a specific provider? So I think we would want to structure some additional reporting requirements around this bill to see if we could isolate for, what changes may be occurring in our systems over time. So a bit of a hard question to answer with specifics to date, but I think looking at, some of the existing data streams we get around provider access, wait times, certainly some patient satisfaction within there, but also, discrete kind of data points like hospital participation in network. Dave, do you have anything that you would supplement?
More on the first part, not on the second part, and nothing to correct either, since you made that little offer. The one other piece that I think is relevant for the commission to think about is if this were to pass and be implemented, it may also make the PEB and SEB portfolios more attractive in the long term to other voluntary participation from other government employers. And why I say that is we've talked a variety of times over the past couple of years about how interim steps and transitional steps could be combining the PEB and SEB programs and getting all the public sector purchasing into one place instead of multiple places. And the more that local governments would opt into the PEB and SEB program, particularly if it becomes more attractive from a rate management standpoint, that might also facilitate and support additional kind of overall market consolidation towards a universal system. So just wanted to highlight that as well.
All right, thank you. Any other questions for Evan or Dave? Thank you, Evan. This was really helpful. I really appreciate you taking the time to explain it all for us. And there's your contact information.
Of course, and if there's a desire for any additional materials, like I said, we'll have more and happy to pass those along through Mary. And you all know how to reach us. We're always available. So. Thanks. Appreciate the time.
Your name dot your last name at hca.wa.gov.
Pop it in chat.
There's a comment. I'm sorry, Liz. Oh,
somebody should put it in chat.
Oh. No, that was it.
That was the right one.
All right. Thank you, Evan.
Evan. So I'm going to just really quickly just frame up a quick discussion here. This has been so wonderful to listen to everybody engaging on this topic, but just, again, reminding the commission of the two-part charge of being focused on designing the universal system. And then also the second goal of being focused on transitional solutions. And this is, I think, an exciting opportunity where the things seem to be coming together with the FTAC really starting to turn and focus on cost containment efforts and some of the models that are policies that could be implemented to do that. And then this recent initiative that Evan went into in depth that is actually being considered in the upcoming legislative session. So we wanted to make sure that we had a chance for the commission to explore whether or not you wanted to take a position on this legislation, and also ask the question if there's additional information. I think we kind of talked about it a little bit already, but if there's other things you want to know about it. So I'm just going to open it up to the commission and ask, does the commission want to take a position on the bill that was described? both, again, thinking about it in both of those contexts, that's something that could make a difference now and something that would provide, some experience for when in designing the universal system. So just want to open that up. Or do we?
I have an opinion, but I want people to talk.
Would love to hear from some of the other folks that have been a little quieter today.
I might start calling on people. There you go, Representative Schmick.
At this time, I mean, you certainly can take a position. I probably would vote no, and the reason being is that I want to see more details about this, about how it's going to affect, especially in the rural areas. Care in the rural areas is a bit unique, and without additional information, especially maybe some background on what has happened in Oregon, I'm probably not going to support it. And that's more of, I just don't feel I've done due diligence on it to take that position. Now, that's not saying that the commission shouldn't give direction and take a position. I am speaking strictly for myself on the reasons thereof.
And your district. And that makes sense. And I think that's actually really helpful feedback for Evan and the team at HCA to pull some of that background together for you.
Mm-hmm.
How about other commissioners, Nicole or Vidisha?
Jane's got her hand up.
Jane. Can't see everybody's face on here.
Yeah, no worries. So Rep Schmick, to your question, we've been doing, because of looking at reference-based pricing for the affordability report, we've been keeping up with Oregon's program, et cetera, et cetera. And their program actually only affects 46 hospitals out of all of the hospitals in the state, because like Evan described, they carve out critical access hospitals as well as sole community hospitals and make sure that those hospitals are paid sort of, and Evan and Dave can correct me, but that it's sort of status quo for the way those hospitals are paid. And when you think about it, the revenue that is, or the spending that's attributable to those critical access hospitals and sole community hospitals is very small relative to the total amount that's spent for hospital services in the state. So it provides an opportunity to carve out and protect those rural and frontier communities. But Evan, you can tell me whether I just messed it up or not.
No, Jane, I think that's right. We didn't take the same approach as Oregon in our proposal here, not because of the recognition of the importance of rural and critical access hospitals, and to your point, the fact that they are such a small portion of the overall payments going into the delivery system. But we also recognize that some of those hospitals are affiliated with large health systems. And so we did want to, ensure that, and we should also note, right, if those hospitals are charging rates that are above 200% of Medicare, those are still direct impacts on rural communities as well. So while we wanted to be really conscious of the sustainability of those facilities in rural communities, and we think we're kind of towing this line and achieving that balance, we also want to be conscious of, our enrollees that are living in those communities are, facing the same burden, out of pocket that enrollees in urban areas are, and in some instances to a greater extent. So try to be sensitive to that and thinking about, still containing costs where it's necessary, but that there is a legitimacy to ensuring a payment floor for those facilities because they are so critical to their communities. And so that's where you see us keeping them within the bill, but establishing that kind of 101% of allowable cost floor for them to ensure that, their rates aren't depressed to a point where it would jeopardize their viability.
I see Rep Schmick's hand again.
And I guess, yes, and I get that, understand that. I just kind of wonder what the far-reaching effects of this would be, especially among commercial carriers, how will this affect for that portion of payment, again, for those rural areas, for those folks? Because it will have trickle effects. And maybe I'm just not seeing that, and maybe there's nothing there either. But that's part of my thought process.
Great. Well, it's helpful to hear your questions, but it sounds like you don't see a reason why the commission shouldn't take a position separate from what your position might be.
I'm certainly not going to want to persuade one way or the other. I'm just, I said I'm speaking for myself.
Sure. Makes sense. Other folks, other commissioners, would you like to take a position on this piece of legislation? Joan?
Yeah, I appreciate the dialogue on it. I, certainly open to taking a position on the bill as well. It's pretty similar to themes that the exchange supported in passing the public option. So appreciate Evan, the shout outs to Cascade Select and the work that's been done across the agencies to work the bill and to sort of see the ways in which there are elements of the bill that has been thought through on the HCA side that we are looking at closely as it relates to the public option, the Cascade Select side as well. So supportive of the effort to try to address affordability and drive some cost containment during this upcoming session, and certainly open to it from the exchange perspective.
Oh, Nicole, is your hand up?
Yeah. So from my perspective, I also think it would be okay for us to take a stance on it. It's something that could potentially save money for the state and for public employees. So I think it's a good idea to consider it.
Badisha or Mohammed? Is Mohammed still on?
So I'll just say that I'm extremely sorry. I'm very guilty of not keeping up with all the reports. I've been just really kind of busy with as the semester is kind of winding down, and I would like to have an opinion, but I want to form a proper opinion after reading all the reports and the legislations, and I just am not there yet. I do think it's important. The cost containment part is really important. I just am not quite sure about the numbers. Like, how do I think about the numbers? If that's realistic, if it makes a practical sense, and what are the pros and cons? So I think that I need some time. I can't do it immediately, but I know that I need to hurry up and read all these reports. So, but I need a little time.
That makes sense. It's a lot to digest in one sitting. And I know there was one of the questions that we do have is, what additional information does the commission need about this? Is it just more time? Is it more information to feel comfortable taking a position?
And I think, thinking about the rural hospitals, I think we know that they're mostly Medicare and Medicaid, and we don't really have an impact on them, on those payments with this work. But I do worry that if we do nothing, that things will continue to get worse too. So I don't want people to feel like they need to be stuck in the paralysis of analysis. And I'm for including this as something we recommend as part of, changing things now and then looking to the universal financing to utilize. Dr. Chima?
Yeah, thank you. And, certainly leaning towards the comments just made by the chair with regards to if there's any action we can take now to limit, to take action on cost, as we should certainly consider that. But I was wondering if Eva and Dave could address? So I know there's probably more information you could provide, specifically looking at the rural hospital area questioning, particularly critical access hospitals and other systems in rural areas. But if I understood the presentation and the setting the floor essentially at 101%, and it seems to me that the question is could you do more? But is it fair to say that it doesn't make the rural systems any worse off, the proposal? Rather, it actually sets a floor for reimbursement that makes sure that you don't go below that floor from what's existing today. So how can you give us? Are you able to answer right away how that 101 compares to the current typical rates to see reimbursements for critical access hospitals? And if not, at least be able to answer the question as to the 101 sort of a flaw that ensures that we're saying we want the hospitals protected, even if there's more that can be done, but it's more of a positive than a negative. Is that correct?
Evan, do you want to respond to that?
I'll do my best. Some of my kind of financial expertise starts and stops pretty quickly here. I'll note, and this gets into perhaps the distinction around price caps and reference pricing that was raised earlier in the meeting. But when we're talking about the kind of price, the general hospital price cap in the legislation, it is a reference to Medicare. When we're talking about 101% of allowable costs here, it is a bit separate and distinct because it's reliant on the cost basis of the hospital itself. So what we're essentially saying is, generally speaking, we're trying to contain hospital prices at 200% of Medicare or below. But we want to ensure that, for critical access and sole community hospitals, their rates are at no less than 101% of allowable costs, which doesn't necessarily have a direct correlation to Medicare. Medicare does tend to pay those hospitals at 101% of allowable costs as well. So it's a term of art that is utilized in other markets as well. But there may be some distinctions facility to facility about, does this require a health carrier to raise its reimbursement rates relative to today? Is that floor slightly below where a facility may be reimbursed today? I think the answer to both those questions is probably yes. I think there's some nuance here. So don't have a perfect response there. But I think your overarching point here of, is this attempting to protect those facilities, and is that necessarily a good thing? I think we would tend to say yes. I would argue, I would imagine certain facilities would view the legislation differently, but I think we're seeing this as, yes, let's make sure we protect their payment floor. Let's make sure that they're reimbursed for their costs, and that there's no point at which they're losing money on direct patient services provided in those settings.
Thanks, Evan. Jane, and then Mohammed.
So I'll yield the floor to Mohammed first.
Yeah, thank you, Jay. No, I also wanted to say I'm comfortable saying we should move forward with this in the interest of time, especially since we've heard from some of the public comments. We're not moving fast enough for many people. So if this takes us a step closer to the goal, I think we should move forward with it. Thank you.
Thanks, Mohammed. Jane?
So, like Mohammed, my thought is to support the bill, understanding, as we know, that as it goes through the process, there will be opportunities to discuss Representative Schmick's concerns related to the impact on rural hospitals and rural healthcare. And for those of us who've been involved in the legislative process, we know that there's a lot of back and forth, and frequently the language is changed over the course of the process. So I think what we would be saying here is we are in support of the principle of using reference-based pricing for PEB and SEB, not only to contain costs, but also to redistribute how we're spending so that we can invest more in primary care and behavioral health, recognizing that over the course of the legislative session, there could be revisions to the language.
I think that's such a great point that we haven't really touched on much, is the sort of the rebalancing, especially into things that we know can make a difference early on, especially given all the crisis that's happening in behavioral health right now. So are folks comfortable with the language that Jane is proposing? That it's not just about cost containment, it's about rebalancing and allocating resources to things that we know are important, that can make a difference. Vidisha?
Yeah, so that part I am absolutely comfortable supporting the rebalancing part. So like Jane said, the language in principle, yes, I do support that. I think where I am a little concerned is the percentage, the numbers,
Okay.
because the slide that Evan showed, I think it said 150% for the primary care and 109% for behavioral, or some the numbers. Yeah, if you could.
Yeah, go back. So yeah, I think it started with right now.
100.
Yeah, go ahead.
Okay.
Evan.
Yeah, so I just but my concern is just, those specific numbers I don't understand yet, and I need to know a little bit more. But I totally am for the rebalancing and kind of channeling more towards these preventative care services.
And the principal language of doing this type of approach, using
Yes.
reference-based pricing to achieve that. Okay. And I think, Evan, jump in here if I'm not saying this correctly, but my understanding is that right now the reimbursement is about 109% of Medicare, and the goal is to get it to 150% of Medicare for those services. For behavioral health, I know that one.
For behavioral health services and primary care, when we actually started down the road of developing this legislation, we were looking at 2022 data and prior. And primary care historically has been reimbursed below 150% of Medicare through our commercial payers. Looking at 2023, we're actually there. We're at 150% of Medicare. But again, leveraging the floor to make sure we sustain that and hopefully invest over time. But yeah, Liz, you're spot on.
I would just say two quick add-ons, Visha, to your point. One, if the prior Cascade Care legislation is any indication, the numbers moved until the final bell. So I think supporting in concept, knowing that they're likely to move a bit is helpful. In our prior experience with the Cascade Care legislation, to Evan's point, we did see some of the floors actually help folks rather than hinder, and sort of bringing up and then establishing a reimbursement level that assisted some facilities. So it really depends based on the facilities, how you view some of the specific numbers.
Dr. Chima.
Yeah, I really like that the approach of taking a principles-based approach to what we adopt. And I'll add, I think it was mentioned, but just for emphasis, in addition to using reference-based pricing to sort of nudge attention to primary care and behavioral health, I'll also add the critical point about the impact on rural communities, right? And making sure that this is done in a way that ensures improved access to all kinds of services for rural communities, because we know that there is pre-existing and significant rural-urban disparities in access to care. So do this in such a way that we lessen those disparities and not worsen them. So including that as part of the principles.
Okay, so it sounds like what I'm hearing from the commission is that they would like to take a position in supporting the principle of what this legislation is trying to do, and focusing on the rebalancing of dollars towards more preventive and behavioral health services. I don't know if we have. Okay, Mary has the language. She's going to read back what Jane said.
Well,
and
I'll go back my notes and see if this is.
Yeah. And we'll just see if and we can move to a vote if commissioners are comfortable with that.
Okay. The commission will take a position in support of the principle of using reference-based pricing for PEB-SEB, not only to contain costs, but also to rebalance resources, and recognizing that over the course of session, there could be revisions to the language of the bill. Does that capture it, Jane?
Yep, sounds good. And I think rather than saying there could be revisions, I would say there will likely be revisions.
Okay.
Based upon my experience, and Evan would probably agree, and Joan as well, and Representative Schmick as well.
Okay.
And me. I've been quiet because obviously I support all levels of details of this bill in the program that I oversee and the agency, it coming from the agency that is bringing the idea forward. So
Great. Okay. So is Vicky, I'm going to turn it over to you to do the
Well,
motion piece, I think,
can we
right?
take that as a motion from Jane and we need a second or?
I
I
second.
second.
Okay, about second and a third. So all those in favor say aye.
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 Oppose, say nay,
I'm going to vote no.
and we respect that. Thank you. Okay, motion carries. We are 9 minutes early for our break, so I'm going to recommend we take it now and give ourselves time for the cost containment. Is that what's next? Discussion, and then come back at 4:01. Does that sound okay? All right, see you guys in 10 minutes.
right.
Hey, we have chocolate. Where's that? There we go.
Okay, 4:01. Are we coming back? We're gonna go back to Liz to talk some more about some cost containment
Great.
concepts. Thank you, Liz.
Yeah. Hello again. I hope everybody had a good break. Just if we can go to the next slide, just want to take us back a little bit to the larger conversation before Evan talked about the current legislation that HCA has been developing, and just the cost containment topic overall that Pam updated us on. So just to recap what we heard from Pam, the FTAC recommendation she shared that the FTAC was interested in supporting the concept of reference-based pricing. They also looked at other cost containment mechanisms, including the public utility model, and some other state approaches to access and affordability, global budgeting. And then finally, they also talked about prior authorization as a potential cost containment mechanism. It came out of the administrative simplification exploration, but that's it, and it kind of focused more on it as a tool to do cost containment. So the FTAC is requesting some more direction from the commission on the topic of cost containment. So if we can go to the next slide, we have some questions that we wanted to pose to the commission to give some direction to the FTAC, and also just circle back to the conversation that you all were having earlier and asking questions of Pam and Bob Murray, who is thankfully on the call today. So first, we want to ask the commission before we go into the questions about FTAC, but does the commission want to continue the consideration of reference-based pricing as something that as a principle or a mechanism for the universal system? So would you all like for the FTAC, or would you like to know more about this tool in your conversations? So just want to open that up, and what other questions do you have about this piece in particular? We
I
heard.
can go. Sorry.
Go ahead.
I didn't raise my hand. I was looking for the thing. Yeah, no, I would say, considering all the the challenge that we've had, trying to attain universal healthcare in terms of feasibility and how to do it right and all of that. I think if but at the end of the day, if we design something that we cannot afford, it's just impractical. So I think this is a very, very important tool for us to not only we recommend something that is not only accessible to everybody but also practical financially and fiscally. So yes, I think this is a great way. This will give us a very good insight into making that decision. So I agree.
And Mohammed, are you interested in the FTAC continuing to explore that? And then how would you like for the commission to be engaged in that conversation? Are you all interested in having a general presentation on cost containment the way that the FTAC did? Because we just kind of touched the surface earlier. And so I just wanted to ask that question of the commission.
Yes, I would really love to be engaged in that conversation, especially as it pertains to other states, especially Oregon.
Okay.
What they've done, states that are in similar situations like ours. I'm only interested in cost being a roadblock for what we're trying to accomplish for the Westerners here. So I would love to be engaged in that conversation as well. If maybe we can have a presentation in the next commission meeting that explains what the challenge other states have faced, especially those that are similar to us, like Oregon, comparison, and then see what other options there are, maybe the better tools to use. Maybe, I don't know. Yeah, but I would really love to know more about it, and I'd like the AFTAC to take on this for us.
And that, I mean, I have to remind folks somebody on the commission has often brought up the Vermont example, that I think it's good that the commission is interested in looking at this now, because the experience in Vermont was that once they did the estimates, it was so expensive, it just kind of disappeared. And so thinking about it at the outset is a really good strategy to make sure that it is feasible and practical. So that makes a lot of sense. Vidisha.
Yeah, so I was just going to say that I would really like a presentation to the commission regarding the cost containment. And I think Robert Murray suggested that he could present the more technical aspects, which I would like to see if that's possible.
Great. Others? Jane.
So, yes to the first question. And while I agree that Bob would be good and helpful, Sarah Bartleman, who is running the program in Oregon, is wonderful, because she'll tell you this is what it is. And these are the warts, these are the good things, these are the lessons that we've learned. So I always think it's really, really helpful to hear from people who are in the states that have actually implemented the policy. And and I think it's fine to hear from Bob as well, but Sarah's just awesome. And then in terms of what other cost containment mechanisms, I do think that it would be, Bob can do this, to really take a look at out-of-network rate caps, because our goal is to have providers be in network. And if there is, and in Washington, I will say that in Washington State, based upon our BBP impact analysis, at least for the services that are subject to the Balanced Billing Protection Act, we're at like 97 to 98% in network. Some people have argued that in addition to creating an incentive to have providers be in network, an out-of-network cap also helps or impacts in-network rate negotiations. Because the provider knows, if I go out of network, I'm going to get X, and that has a role in the discussions related to in-network rates. And If Bob has concrete examples of other purchasers or other states that have pursued a policy like that, I think that would be very helpful to hear as well. I mean, we states, and Representative Schmick knows this from all the work we've done around balance billing issues, the states are always learning from one another, always.
Vicky.
I'm interested in learning more about the public utility model too, because I think that's something that will be more useful in a universal financing system. And I have a lot of interest in global budgets. I know I've talked to our hospital administrator about it, but as Pam pointed out to me that we mostly have Medicare and Medicaid, and those are the two the two things that we don't have control over right now. But I'm just thinking, I don't know how a global budget would work if we're only working with part of the healthcare system. So if there's any example of how that could look, I guess.
Okay, global budgets, public utility model, out-of-network payments, Oregon. Joan.
Yeah, thanks, Liz. Yes to the first question. I think there are lots of elements that cascade here that align with the universal health coverage group, and I think reference pricing is one. This is probably not the most sexy suggestion of the day, but in terms of cost containment mechanisms, we've been thinking about what kind of data reporting, transparency, enforcement mechanisms need to be in place to make sure they're working. So I don't know if that's just a component of reference pricing or just something that's sort of more broadly, something to think about more broadly. And then Jane, I don't know if you would consider it cost containment. I thought the MLR stuff in your affordability report was interesting and sort of on the consumer protection side of making sure premiums go to pay for the costs. And I know there were some impacts and some cost savings associated there. Not sure if that's one that you all are looking into more or this group should or the FTAC should, but I thought the findings in the report were compelling around that.
Yeah, I mean, if we assume that we're using a model where where you're contracting with entities to administer the benefits, then the question becomes, what percentage of cost allowable, is allowed for admin. And so the MLR is sort of the analog to that.
And I don't remember, did the state also adopt the same medical loss ratio as the ACA?
Yep.
So it is.
And in the affordability report, we modeled taking it up to 88%.
Thank you. When you say MLR and Indian Health, that's Medicare-like rates. So
I am sorry.
No, it's okay.
MLR and
Medical loss
ACA
ratio.
speak is medical loss ratio. My apologies for using alphabet soup.
That's okay.
Other folks, are there other policies you're interested in hearing about related to cost containment? It sounds like there's definitely interest and energy in making sure that this is part of the universal, the system design overall and learning more about it. But Nicole.
I've been thinking about this for a while, and I don't know if it doesn't, it could be a cost saving effort potentially, but like even our administrative code, right? There are probably things in there that could be adjusted that could potentially either produce some cost savings either on the administrative side or things like that. I don't know if that's possible. I haven't really fully formed that thought, so I don't even know if I'm making sense at the moment.
I maybe I didn't hear correctly. Did you say looking at the Washington Administrative Code to see
Yeah.
whether there are things that we could save dollars on?
Yeah. And or provide better access or faster access, those kinds of things.
Okay. Any other commissioners have thoughts on that?
Has there been any reports done on that maybe already? I mean, who would do a report like that? The insurance carriers?
Yeah, I'm really curious about that.
Yeah, no. I think it's an interesting angle, Nicole.
I think we'll have to take that back and kind of noodle on it a little bit. Yeah, we're really, I mean, I think this is the fun part because we're, for you all, thinking about, I think that I always think about the rebalancing conversation in the world that you all are making up in the new system. You're going to get to make those kinds of choices about, do we allocate our resources over here or here, and what do we want to design that's, it doesn't have to be the way it is now. So I think that's trying to think outside the box, I think is really a really good approach to that. So I think this is the opportunity to bring up anything that you think is going to be a cost containment effort that we can find more information on and bring it back. Or ask the FTAC to do too.
So chiming in quickly, I think the other area that could be looked into is the cost of, prescriptions rather than pharmaceuticals in general. Because that's something that also has significant impact on the consumers, and particularly knowing that in this one of the concerns we have the U.S. healthcare system as it exists today is that we're an exception when it comes to being able to negotiate the rate of new products in the market compared to other countries. So is that something that if you're thinking about a new universal system, that could be a concern because that could continue to cost out-of-pocket cost concerns too, and general cost increases to the system. So that's something that can be looked into as part of looking at cost considerations, is particularly looking at pharmaceutical products and how that should be factored in.
Great. And I know there is the pharmacy, I can't remember, it's PDAB is the acronym. There is something in the state looking at specifically at the state, but I also know there's been conversations about aligning with other states on purchasing eventually. So we can definitely come back with some of that information. Others? Bob, I see you there. Are there other things that you would want to throw out to this group that you haven't heard anybody talk about that might be worth considering?
Well, no, I'm very encouraged by this discussion. I think your observations about focusing on affordability is really the key. And generally, I think a discussion around what is a prudent and responsible strategy for capping provider prices and constraining cost growth and spending growth is very important. So I certainly would be happy to provide a short presentation on any of these topics. I really like the price cap approach that Oregon is taking because it's shown to be effective, and it sort of demonstrates a proof of concept in terms of containing costs, but at the same time not having deleterious impacts on hospitals. And so that's very important because in rate regulation, you have multiple goals. One would be to contain costs. The other is to avoid disrupting the delivery system, and take gradual steps to achieve your cost containment goals. And I think that's what the Oregon approach does. And then once that type of strategy is shown to be successful, then a state can potentially move on to other areas of cost containment. Jane has mentioned out-of-network price caps. I am a strong believer in that and can certainly come back with some examples of where that has worked and how it can work. And then broader cost containment mechanisms like hospital global budgets. And then the public utility concept is really more of a governance concept for a broader cost containment model like hospital global budgets. So, but just let me know. I'm very happy to discuss these and fit it into whatever time frame would be appropriate.
Great. Any last words from commissioners before we move on? It sounds like there's a lot of interest in learning more about these various policies or tools, and having the FTAC do some of that, but also getting a grounding here in the commission on these topics and some of the things that the FTAC is diving deep into. Okay, I don't hear anything else. So the team will take it back and be prepared to learn more about all these policies in the new year. So I'm going to turn over to you, Vicki.
Well, I think I'm turning it back over to you, right? We're gonna talk about our 2025 work plan.
It's Mary.
Mary, okay, sorry.
Up on that one, Vicki.
All right, Mary.
Thank you. Next slide, please, Audrey. Okay, so I might be skipping through a few of these slides. We're running a little bit late. I'm good at talking fast. Todd gave me chocolate, so let's see how we do between now and 5 p.m. Talk about the objectives coming up for 2025, the legislative directive that put us here in the first place, our new milestone tracker, which we've already heard some feedback about today. Thank you, everybody. Some proposed goals, the meeting schedule and the overview. And then the discussion at the end is just to make sure that the goals and the schedule and everything else make sense to everybody and, make changes to that if we need to. So the next slide. Yep, we're going to review our current progress, look at our plan, and potential opportunities for improvement to our meeting structure and some of our processes. Next slide. This is always good to revisit. Liz mentioned this earlier today, that there's two parts of the commission's charge: immediate impactful changes, the interim solutions, transitional solutions that can be put in place without a universal system in place, things that can improve what we have now, and also the universal system design. So we're always kind of holding both of those in balance as we move forward with the commission. Next slide. Here's our tracker. This is something that folks have requested. I hope it illustrates where we are, what we've done. We welcome feedback on this. It's got the green stuff that is done. The yellow is in process. And the gray are the things that are have not begun yet. So there's a lot of information here, but I hope this gives a good snapshot of where we are. The legislative reports, that side is just going to keep growing because we do these reports every year. The next slide. So here are the proposed three main goals in the realm of universal design. Complete the analysis of benefits and services and determine prioritization of benefits and services to be included. Develop a set of recommendations for cost containment mechanisms. I think we heard plenty of interest in that today. And develop a set of recommendations for provider reimbursement and participation. So if we go to the next slide, this is the tracker again, and putting it in, the previous slide and this slide combined are basically saying those yellow things on the left, let's turn them green in 2025. And then early 2026 is when we begin to tackle the financing picture. So that's the universal system design goals for 2025. And the next slide talks about our transitional solutions, the other side of the coin of the commission's work. Complete the analysis of administrative simplification, develop recommendation or recommendations, see where we land. Continue to maximize leverage and expand the current programs. And then as we go through the year, identify additional transitional solutions to explore. That's a player to be named later of what the next topic is that we will look at. So the next slide, here's our meeting schedule. Just a reminder of the dates. You all should have received your invitations this week. If not, let us know. Shoot us a quick email, we'll send them. All these dates are Thursdays, except one. I think it's June. One of them's a Wednesday because of room availability, but it's mostly Thursdays going through the year. And the next slide. This again is just at a glance what we were talking about, getting through phase one, getting through those three pieces, sticking with the transitional solutions, making the FTAC assignments, and then our legislative requirements. We were going to do a ledge report in the coming year. And then all of us need to do our Open Public Meetings Act training every 4 years. And Liz, I realize I'm doing all the talking. Do you want to jump in at all?
I was gonna leave this to you, Mary, and I'm getting a note that my internet is unstable anyway, so
Okay,
take it away.
all right, next slide. Here is the work plan. We tried to show this graphically. I apologize, the print is small and initially the colors may be a little confusing. But I'd like to explain what we see as the flow of the work. The January FTAC, if a topic is in black text and not bolded, it's sort of an ongoing, we're working on it, you know, on the agenda going through. But if you go to February commission, you would be considering the preliminary prioritization of benefits and services, and then a final recommendation for prior authorization. And if you look back to January FTAC, that's where that comes from. A lot of that input comes from FTAC. And then anything that's orange is in process, and anything that's red is here's where you make your final recommendation.
Mary,
Yep.
Jane has her
Oh, yeah,
hand
hi,
up.
Jane.
So Mary, the one thing that I'm thinking about, first of all, this is lovely. Having things laid out so concretely like this. Thank you so much. On the February, where it's like preliminary prioritization of benefits and services, if I remember correctly, I think Pam said we weren't going to have the information back from Milliman until March. So do you want us to be having discussions like this without having the Milliman report? That's the one thing I'm thinking about.
That is a good question. When we say prioritization here, we are thinking, looking at the include benefits and services, come up with an initial prioritization, knowing that as we have more information about cost, that those priorities may shift. So it's more of an initial stake in the ground, knowing that it may change as we go down the road. If it makes more sense to move it later in the year, we can do that if you'd like to have more information before you do the preliminary.
I guess I'm wondering, what information will we have in February? Let's think about it that way, that we would discuss. And I'd love to hear from other commission members too.
I'll pause for a question and then I'm sorry, there's a hand up. I can't see who it is now. Oh, Mohammed.
Thank you, Mary. No, I wanted to actually go back to especially the comments that we were getting from the public, like everyday Washingtonians, around the length of this process, the duration. And I don't want to speak for everybody, but that I think we should go back to monthly meetings, maybe just to expedite things. I know I'm asking for a lot of work, but I think if we really need to do this and do it right, I think we might be able to invest a little bit more time into it, instead of every 2 months, maybe monthly meetings, or even, I don't know. But I'm just throwing that out there.
Yeah, and I thank you. And I also want to, should have said this when we first started looking at this slide. In between meetings, think of the curves or the in between the months. We foresee a lot of staff work, taking information from FTAC, organizing it, putting it in some kind of standardized format, bringing it to the commission. The commission makes recommendations, makes changes, have further questions. It goes back to FTAC. So there's sort of a flow of the number of times things go back and forth. And what we see is a lot of staff work in the middle, organizing and supporting the discussions and putting forth, what you might endorse, not endorse, edit as you go along. Another question we have later on, but I'll just bring this up now. What's a reasonable amount of work for commission members between meetings? And the announcement we sent out about this meeting had, if you have time, please listen to Bob Murray's presentation to FTAC. Now, our apologies, the recording was a little messed up, and so you can't see the slides and the presentation at the same time. We know how to fix that, but sorry about that. But is that a reasonable ask? Is it more reasonable to ask people to watch an FTAC presentation, read materials? Sorry, I jumped the gun on that question, but I'm curious what people think. Or meet every month.
May I again? I trying to figure out where it is. Yeah. There you go.
Mohammed? Sorry.
Yeah, no, I wanted to, I also wanted to ask, maybe the meetings, the after meeting and the commission meeting, if we might, if we can afford to get like a very good time between the two, so that we have time to read and analyze or even respond in an email. The way they are right now, at least for my calendar, it seems to be back to back, like 2 week, like a week apart or so. To get more information through an email, yes, I don't, you know, I would like that, but just to get enough time to digest everything before I come to the commission meeting. I don't know if the schedule could be played around with, but that is my only
Thank you.
suggestion.
Nicole?
Oh, sorry, I didn't see your hand.
That's okay. I think it's reasonable, your suggestion, you know, of either watching something in between meetings and or reading. It gives people an opportunity to kind of really digest information versus being talked at. But, you know, that's, I think, you know, I'd like to hear from other people how they feel about that as well. But that's kind of my thought process.
Okay, I can go back to, please feel free to jump in with questions or put your hand up, but I'll get through to the end of this deck. So Audrey, if I could have the next slide. Pretty similar, it's the second half of the year. And again, you can see how we initially have envisioned the flow of various topics, and we can change orders of things as we go along. November, December, just say future topics, and that's because we figure things will come up, topics will move, schedules will change, and so we just left those open, figuring that there would be, by the time we get there, there'll be plenty to fill those in. And if you notice, it says updated November 2024 on this work plan. It will continue to be updated as schedules and things change. So the next slide. We get into our discussion questions. And we already talked a bit about the second one, but we'll go back to the first one. The goals and milestones that we laid out, you know, getting to those 3 yellow pieces, making them green, getting to financing in early 2026. Are those the goals and milestones the commission wants to pursue in 2025?
Can you pull up the progress chart again? Sorry.
Sure. Audrey, can you go back to it? The tracker? One more. There we go. Thank you. So again, it's taking, for the universal system, it sees 3 yellow ovals and turning them green.
So benefits and services, cost containment mechanisms.
Provider participation and reimbursement. I mean, they're all in progress now to a greater or lesser extent. A hand is up. What is it?
It's me, it's Nicole. Yeah, I think that's a good method. We've already been talking about them, so you might as well wrap them up.
Thoughts?
Yep, I agree.
good with those.
I realize my verbal head nodding yes isn't recorded very well, so I'll verbally also echo those points.
Okay, thank you. Okay, then I think we will take that as our direction in the coming year.
But, and Mary, I think I heard the need maybe to be notified when the FTAC recording is done, maybe, or so people will know that we have some time to check out what happened in the FTAC meetings. I know I fully intend to go every single time, and I think I get a meeting scheduled right over it every single time, so.
And perhaps what we could do is, I mean, we'll send the link, obviously, but maybe send timestamps. Here's where they talk about benefits and services. Here's where
Oh,
they talk
that'd be really great.
whatever, and we can give you the timestamp if you want to go straight to a topic, or if they, there's research papers they discussed, we can make sure we have links to those. So we can sort of give you
A summary, a high point summary.
highlight summary. So
Yeah.
'cause
Mary, that would be great. Getting the cheat sheet version would be.
Yeah.
that's the word I'm looking for.
Because the longer summaries take time, but the video is available with like a quick cheat sheet right away. Not right away, but within like 2 days. So that's easier to do.
Yeah.
I think that might be helpful, yeah. Thank you.
Crib notes, especially during session, I think are appreciated.
Yep.
Yeah, total ditto on that one.
Okay. We can do that. Okay, Audrey, can we go back to the very last slide? Because I don't remember our third discussion question. Here we go. Dividing time between transitional solutions and universal system design recommendations. I mean, what we had for the priorities for transitional was wrap up some of the admin simp work and then identify another topic. I mean, if you go the picture that shows the work plan, I think we just say next topic or topic 1 or something. We have a generic name for it because it hasn't been identified. I don't know if there's feelings about the way you want to split your time.
I think piggybacking on the concept of session is coming, maybe focusing a little bit more on universal system design while we see what does or doesn't make its way through the legislature. And we're all in a very, the very beginning of this meeting was about how much change and difference there will be, that we're all understanding and navigating in January, and kind of understanding like what the conversations are like for the kind of short-term immediate. That makes me start to think about the transitional things. There are a couple of irons that might be in the fire when it comes to the affordability bill that we talked about earlier in this meeting. I highlighted that a PEPSUB consolidation report will be out in about a week and a half. Part of that report has essentially draft legislation that could be picked up because the report asks for all the statutory changes that would be necessary to effectuate the topics of that bill. So there's a couple of things that relate to some of the transitional topics we've been talking about. I think we need to kind of see how some of that shakes out in the new and different changes in state and federal government, and that focusing on the bigger question at the earlier part of 2025, and then moving back and taking a lay of the land and working then later in the year on the transitional solution piece. That kind of makes sense to me.
Thank you. Jane's hand is up.
Yeah, I totally agree with Dave, because as much as I don't want to say these words, given what the budget outlook is, I think what we're going to need to do is we're going to need to step back at the end of session and just sort of say, where are we now? And we may have some sense of what's going to be happening federally, maybe a little bit, but anything that we do on a transitional basis, I think is going to be heavily impacted by whatever the legislature does. So I completely agree with Dave.
Any other thoughts? I'm sorry, Tom.
Anybody, yeah, disagree with that, I guess, would be the question. I think it'd be important to hear, like, we'll be February and April, kind of where these bills and anything that comes up are going, and but really focus on the universal design. Be great. Nicole,
Any
Patricia.
other thoughts about timing, emphasis?
Oh, I agree.
There's a hand up, who's?
Nicole agrees.
Oh, okay.
Sorry, I didn't realize you expect, I'm shaking my head over here too, like, I'm nodding. Yeah.
I saw a thumbs up from Joan earlier. That's not easily recorded either. So
I agree. I've been nodding my head too.
Yeah, concur.
Okay. Dr. Chima Mohammed. Representative Schmick. I saw your note in the chat box there, Representative Schmick. It's gonna be rough. Yeah.
Hand up, and it is Mohammed's hand, is it?
Yeah, sorry, I have the little ones behind me, so muting myself more often, not to disrupt the meeting. I'm still stuck on the timing part. Can we do better? What is this timing based on? I just wanted to see if maybe if we can add a little bit more meetings to move things forward faster. But I don't have the whole picture to make this, and I don't know how the decisions were made. But I'll still suggest or put forward the suggestion that we could move faster than, especially to see the when you look at the progress, the milestone tracker. I think we've done a lot of work over the years, and it would be nice to see, at least from my perspective, that some culmination of hope for people out there that are frustrated with the system, or that do not have access to the system as it is. So I just wanted to report that.
Thank you.
I know that there is limited funding for staff. I think so that's why the meetings are structured the way they are. I'm wondering if maybe there's a time when we could have a joint meeting with FTAC, maybe, if we're really trying to get something moved forward quickly. I mean, that might be an option.
Yeah, to me, the challenge is just the dependencies on the analytic work that staff and Milliman and the FTAC are doing. So to me, the frequency of the meeting isn't as important as having the analysis and the information available for us so we can make decisions and move forward in a timely way. So that's how I think about it, Mohammed. I think about it as we had more frequent, shorter meetings, then we changed them to less frequent, longer meetings with the idea that in between more of the substance could get done so that at these meetings we would have information available to us to make informed recommendations, which is an approach that I appreciate rather than more frequent. Like, we're only as good as the information we're provided. So if we're not, unless there's going to be a concurrent increase in the outputs that we're able to see and analyze and have inform our decision making, I would feel uncomfortable meeting more frequently with less information. And I think until there's resource dedicated to think there's a dependency on resourcing staff in the way they would need to be staffed to meet it. That's my hesitation, completely hearing the urgency and the desire to move quicker. I'm sympathetic to that as well.
And I think we have a good foundation, and we'll see some better movement in the beginning of 2025. Dr. Chima.
Yeah, I just wanted to add to that conversation. I share Mohammed's sentiments with regards to wanting to move things along, but also share John's comments about ultimately, I think what with moving things along is really about being able to get to decisions and close the topic and move to the next item of decision, which goes back to the point about the analytical work being critical to that. So I think, if you look at it, something is happening every month, right? It's either there's an FTAC or there's an UHCC meeting. So I think all those go hand in hand into informing decision making. So I think the emphasis could be on what was said earlier about, particularly when it comes to issues that are gonna come up for vote, right? So if there are critical elements commission members are gonna need to, so if one needed to have watched an FTAC video or needed to have read a material in order to be ready for a vote. Just the staff really helping us just because as everyone on the call has a day job, right? So just really paying attention to calling commission members' attention to say, hey, it would really be helpful if you looked at X, Y, and Z materials or video, whatever that looks like, because it will help inform your vote on so and so topic at the next meeting. And that way we don't come to a meeting and the commission members feeling like they don't have enough information to give their votes on that meeting and potentially delaying the vote another 2 or 4 months. So I think that will help move agenda along. It's just helping us with some of those it's almost like a pre-work or assignment or whatever that looks like to say, if you did this, then that will really help us be ready. And then if you have your questions, put that across to the staff so that they could potentially begin to have your answers ready for those questions by the time we get to the votes at the meeting.
Thank you. And I think, do we have like 3 points of taking like a vote or having a decision to move forward at this meeting? And I think that's more than we've usually have in the past. Yeah.
I'm sorry, Becky, I didn't hear your question.
I was just saying did we have like 3 different points during this meeting or 4 where we had to make a decision on how something was moving forward? And so I feel like, again, we're at that point where we've got enough of the foundation that we're gonna start being more in the, yeah, let's do this, yeah, let's not do that kind of decision making. I was just talking, Mary. Any other thoughts on any of these questions, but mostly the transitional solution versus universal system design? And I just, I know this is tedious and people get a little frustrated, but it's good for us to hear what other states are doing. But we do really have to make decisions based on the landscape here in Washington State. And we're a very progressive state, and we have the opportunity for everybody in our state right now to have access to coverage. Is it all affordable? I mean, that's something that we need to work on. So I appreciate the patience to really make good decisions, because I know when we rush things, the people who get hurt are, and this coming from my experience working in the Indian healthcare delivery system, the people who get hurt when we push things through and we haven't thought through all the way are the most vulnerable people. And I think that's what we're trying to avoid. So I just want to be mindful of that too. Mohammed?
Yeah, no, I agree with you 100%. And I also think we should maybe, and it's too early to say this for sure, but between a transitional solution and the design itself, if we can get something to the people, especially those who do not have access right now for whatever reason, cost, availability, all of that, get something to that covers, at least covers our base, and then maybe get some feedback while we also work on designing actually doing the actual design to make the improvements, or study the weaknesses of the transitional solution. It's all of these things are way into the future. But I agree this maybe 50-50 time, or I don't know, 30,
Yeah,
70.
maybe after session 50-50. Once we know what they decide in session, and then
Yeah.
okay. Yeah, and I think, in the exchange meeting I was in with Joan before this, there was a presentation on the breakdown of where uninsured people are. And I don't know, the other thing is the small businesses, and I think we've talked about this before. There's small businesses, they can't afford to cover people because of the market, and then maybe they choose not to, but what are things we can do there? Because I think they hurt just as much as the people who don't have any access. When you have access to coverage you can't even afford to use. Mohammed?
Yeah, sorry for the backup. Thank you, Vicky. No, I'm one of those small businesses. I pay
Me
half
too.
my salary right
Yeah.
now to cover
Yeah,
my 4 kids and my wife, myself.
that's definitely
And
unaffordable.
yeah, it's very unaffordable for me, even for me right now.
Yeah. So, yeah, I'd like to see us have those conversations. Anybody else have any thoughts? Mohammed, was that a new hand or, oh, okay.
I was trying to lower it down.
Okay. Vidisha, any thoughts? Nicole?
One quick thought,
Oh,
Vicky.
Mhm.
If
Okay.
after session, I would love it if we could have an in-person meeting.
Such a good idea.
That's
How do
something
you-
we have considered, something we are thinking about. We are currently assessing things about like the directive and the travel ban, so, or travel
Right.
freeze, not ban.
So we could have an
We could just do
in-person
travel
meeting in Olympia because the staff can't travel.
Yeah. But Jane, I really do like that idea, and we'll see what we can do as
Yeah.
we, assessing the landscape under the governor's directive.
Yeah, and maybe that's an opportunity to have a little bit longer meeting, Mohammed, and really talk through stuff. Maybe we can bring in the FTAC for part of the day. Oh, sorry, Nicole.
oh, it's okay. I kind of commented, just like on the work plan and the way it's been going, having the FTAC meet and then us right after. I like the way that that's working out, as compared to before. I feel like we have like more opportunity to actually like discuss and vote. And then the other part of it, the transitional solutions versus universal design. I do think that during session, universal design should be like our main focus, and then transitional solutions and a combo with universal design after, right? And that way you're kind of like in the interim getting prepared and kind of learning a little bit more about what could be recommended in our report towards the end of the year, right as session's about to get up again. So
Thank you. Okay, anything else?
I just wanted to say I would love an in-person meeting. Wanted to see these great people that I've been working with for this long in person and say hi.
That would be really
That would be
great.
fun.
And I think, I don't know, in Indian country, we bring our kids and our parents if we're caretaking, just putting that out there. To me, it's culturally appropriate. I don't know how other people feel about that.
Dave and I are on tap to make fried egg sandwiches, obviously, for everybody.
Arrange them. We're not making anything. We're arranging. I'm definitely incorporating that word, Joan, in the future.
Yeah, I think I'll bring my own lunch. Maybe I'll make some soup for y'all. All right. Well, I think we're done then. Everybody feel done? Okay.
Thank you all very much for the feedback and the comments and everything. It's super helpful as we plan out the year. Appreciate
Yeah.
it.
Yes, thank you. This was really, it was a lot. I mean, we did
a
make
lot.
some really good decisions, and I feel like we're in a good spot going into the new year. Just want to thank you all for your continued participation. I know it is a big chunk of time that's dedicated, not just the time we have in the meetings, but reading all the materials and thinking about stuff. So I appreciate all of you. The recording for today will be up on the HCA website shortly. Our next meeting is Thursday, February 13th from 2 to 5. That will be during session, so we'll see how it goes for attendance. And then I look forward to seeing there. And we'll for that meeting for the in-person meeting at the end of session. So thank you and have a great evening.
Thank you,
Thanks,
everyone.
Vicky. See you all in the new year.
Bye, everyone.